We'll get started. All right. Good morning, everybody, or afternoon, or good night, wherever you are in the world or at time that you're watching this video. This is SEVA VentRounds. Today is January 28th, 2025, and we're gonna do an event that we call the 2 pauses, 1 happiness in bedside assessment. All right. So disclosures, there's no endorsement of any mode, ventilator, or manufacturer. Whatever we say, it's our opinion. It does not represent the Cleveland Clinic. I'm Eduardo mireles-cabodevila and Rob Chatburn. Here are some of our conflicts of interest and disclosures for all of you to be aware and connected. Just keep your microphone muted. If you want to make a comment or connect, please just either unmute yourself or put it on the chat function. We're monitoring both, and we're happy to interact both ways. So have no fear at all as you're talking or going through these items. Alrighty. Next item is there are CRC points that we give for being part of this event. So just go ahead and send those as you are completing your evaluation in 1 hour. Okay.
Yeah.
In terms of key knowledge, this is where I wanted to start, and it's our belief and part of our key teachings in the SEVA program that all patients should be assessed, and this means all patients on mechanical ventilation should be assessed with a end-inspiratory pause and an end-expiratory pause. That's a key skill that we expect on every patient. Every time that you do an assessment of the patient-ventilator interaction or the patient itself, you should do these 2 pauses. One gives you, if the patient is passive, it gives you the plateau pressure. If the patient is passive, the end-expiratory pause will give you the auto PEEP or total PEEP that the patient is receiving. And if the patient is passive, the end-inspiratory pause will give you a concept that is called the PMI or pressure muscle index. And if it's an end-expiratory pause and the patient is active, you're going to get a measurement that we call the POC or occlusion pressure. And just remember that the difference between P-plat and total PEEP is the driving pressure. And so you want to, I think that in modern times, as we are evaluating patients and risk of injury, these are the basic things that we would expect to have done on a patient that it's breathing, if you can. Now, some ventilators have their challenges to doing some of these measurements and measuring them, but if you can, this is a good practice. All right. Rob, any comments?
No.
Okay. So this is our first case, and today I was walking around the unit, and there was a patient, and I turned around and I saw this the same picture that we downloaded. It's that, and the reason I stopped was because I saw the waveforms. I said, oh, there's something there, and that's how it all started. So I would start by the team. If you want to tab right on the chat or unmute yourself, either or, and just tell us what do you think is the tag for this mode. Right. Give you a couple of seconds as we usually do. Good to see you, Guayo. Nice to see you connecting. And I see people rapidly entering the tag for this mode appropriately. So we left the mode up here, so it's ASB, and the tag coming in is PC-IMV 3 OI. And we'll talk a little bit more about that in a second. Then the next question that I have for you is, what's the load? Okay, start seeing right. So I see a fair amount of PMOS coming in. Right. I don't see more. And then I would ask you, since there's PMOS, what's the PV discordance? So then let's go in order. Let's go from trigger. So is it normal, early, late, false, or failed?
It's normal.
Have no fear. This is where you test yourself. And so I see a couple of early.
Oh.
I hear a voice if you want to mute yourself, or unless you want to make a statement. So I see a couple of earlies, one normal, and some failed. That's very good, and one failed. All right. Let me then ask you, all right, what about the inspiration? Is it assistance, over assistance, under assistance? All right, so I see a couple of under assistance. This is good. There's a lot to unpack over here. So I really like you guys really committing. This is how we learn. We put it out. What about the cycle? Early, normal, late? Cycle, normal, early, late. See a couple of normals. And a couple of earlies, okay? So normal, oh, sorry. Normal or early. See a couple of earlies. Very good. I love that you're committing. That's okay. I'm just highlighting what you're. Then we're gonna dissect this waveform, okay? And finally, during expiration, do you see any work, expiratory work, or is it normal? Yeah. All righty. Very good. So thank you very much for sharing your thoughts. Now let's start unveiling a little bit this, and we're gonna do it with some of the annotations that Rob placed and talk a little bit through this, okay? So I think for all of you that said this was PC-IMV type 3 OI, you are absolutely correct. That's the tag for this mode. It's pressure control, and you can rapidly see that because the pressure is constant during inspiration and the flow is not being controlled. There's a lot of irregularities there. So that's consistent with pressure control. Rob, do you agree with that?
Yep. There's
Then,
a typo though. It's IMV, not IMIV.
there it is. So
Going too fast. Yeah.
that's okay. IMB, and so in terms of IMB, if you had been seeing just this waveform, you would not have been able to detect that this was IMB. I will put it there. This is one of the great challenges of the commercial names, that you would not be able to know that this was an intermittent mandatory ventilation mode. This is because right now all the breaths are being triggered by the machine. And we know that because in this ventilator, it adds a little triangle below whenever it's triggered, and it's colored according to what is triggering it. 3, Rob, do you want to tell us a little bit what 3 means?
Yeah, there are 5 different kinds of IMV, and they're all essentially changing mandatory breaths into spontaneous breaths, or letting spontaneous breaths suppress the mandatory breaths so that they're out of the way of the patient if they have a normal trigger effort. So IMV3 means that mandatory breaths will not appear if the spontaneous breaths maintain a minute ventilation above whatever is set by the mandatory rate and time, rate and tidal volume. Whether that mandatory rate and tidal volume are set by the patient or the ventilator doesn't matter.
Fantastic. Thank you, Rob. And then OI stands for the targeting scheme, and O means to the, and I like to put this graph here because that will help you identify exactly what this talks about. The OI, the optimal talks about this curve over here. And this curve is the relationship between frequency in the x-axis and volume on the y-axis. And it's the optimal combination that gives the same minute ventilation for the least amount of work of breathing, or power, if you, which is by rate. And so the machine has used an equation based on the minute ventilation that you have delivered and the weight, or height of the patient, that will deliver this combination. And it chooses the best optimal combination of tidal volume here and volume and rate. Sorry. So that's the optimal part. Rob?
The curve actually is all the combinations of rate and tidal volume for a passive patient that will give you the percent minute ventilation you have set. And the dot, the green dot, is what you just said. That's the optimal based on the resistance and compliance and the Otis-Mead equation. Excellent.
And then the box, the square box that you have here, it talks about the I part, which is a level of safety that it's embedded into the device. So the upper and lower borders of the box are the lowest tidal volume that the algorithm will allow, and the highest tidal volume that it will allow, thinking about lung protection and hypoventilation based on dead space and whatnot. And so this would be the highest tidal volume, and this would be the lowest tidal volume that it would allow. And then in terms of frequency, it has the lowest rate combination, and then the highest that would prevent auto-PEEP, or based on the time constant. And this could be based on other rules that are behind. We don't know exactly what are the rules, but this is what the manual says. So that's the intelligent part. And so you have this box, and essentially the algorithm is going to try to keep that green dot there. And then you can see the yellow X or cross that you see there, or plus sign, and that's what the patient is doing currently. And so whatever the machine has targeted, it's being done right now by the patient. One is on top of the other. Rob?
Nothing further to add. That's very good.
Okay, that's perfect. All righty. So we saw the tag, and we saw what that means. And in this case, it put a rate of 22 and a target tidal volume of 301. That was the combination. So the load, you all chose PMOS, and I presume that you chose it the same way that I did as I was walking by, because you saw this stuff over here. And that thing that it's right there, and you can see how regular they are. And so you see them and said, this looks like, and some of you said failed when it happened here by number 4. Some said early, oh my, what happened here? Close the, sorry, that's why I should not have opened it there. Open PowerPoint, sorry. My apologies. We'll edit this piece so I can play a violin. You're muted, Rob. It's here now.
Same thing happened to me last week.
All right. Oh, really? Oh, that's sabotage at 7th. Okay, so here we were. And so you see these items here, and I thought that this was PMOS as I was walking, but it's they aren't very regular PMOS. So I was thinking, well, maybe it's a very restricted patient and there's still effort, and that's why I'm seeing this. So sometimes that can happen, that the patient has a very slow inspiratory effort triggers and then continues, but the compliance of the lung is low, and so it cycles off, and that can occur, so that there's an early cycle. But in this case, the ventilator it's not being triggered by the patient, so it doesn't recognize that. So I was a little bit confused. So my initial read was indeed PMOS, and I will show you in a second, and you're gonna slap me, but that's the case. But if you look at expiration, and always remember, if you see PMOS and you cannot see it, look at the expiratory phase. And here you can see the exponential, it returns in less than a second back to baseline. And so that would go with an elastic load. And just for kicks, this machine does give you the static compliance when it's measured. And you can see that the last time, or what you have here is the 24 elastic and 9 of resistive. So the resistive load is normal and the elastic load is high. So just for you to be aware there. And so that's what Rob highlighted. Now, Rob knew a little bit more than us on this, about these little oscillations here. Rob, you chose elastance, and you want to comment a little bit more. Is there other item that you want to highlight here?
Well, two things. There are two clues on this slide. The first slide, the first clue is in the flow waveform. As you indicated, flow decelerates or decays down towards zero very rapidly, right? So that's a short time constant. So that would indicate that the elastance is high and compliance is low. And down in the box where the ventilator monitors resistance and compliance so that it can do the optimal targeting, it tells you that the static compliance is 24, which is very low. Severe ARDS is like 35. So yeah, that's very low. So that's another indication that there's an elastic load problem.
And then we went to the patient ventilator discordance. And in patient ventilator discordance, we heard different things from normal to early to failed. And I just want to highlight on this slide is that just remember that when you see the first discordance that you see is the one that you treat. And so for those that say normal, well, you would continue reading. For those that you said early, then you would try to treat the early part. So you would try to unmask this. For the others, that the one that said failed, you would say, well, am I over assisting or is there auto PEEP? But I don't see any auto PEEP. So, and this is the reason why the pauses are so important. I want to highlight this. The first one, and I love what Rob put here, is that all the breaths are mandatory. So the triggering threshold is not being met if this is PMOS, or this is that would be the first one. And you see the distortions on flow. So this is where the end-inspiratory pause comes into place. So again, we went to the bedside, we did an end-inspiratory pause, and now that you see the end-inspiratory pause that is blocking, what you see are these beautiful oscillations that are on the pressure waveform, and they are very rhythmic, right? You can see how they match, and the flow is close because we close that. So these are cardiac oscillations. So all these oscillations that we were seeing here are manifestations of the cardiac oscillations. And this end-inspiratory pause helps us, not that it's the one that we will do, I'm going to show you the next one, which is the end-expiratory, but this is consistent with cardiac oscillations. This would be the plateau for these patients. The other item that I would highlight is that there's a concept that now we call the PMI, or passive, the pressure muscle index, in which is the amount in a patient that is doing effort that the plateau would elevate above the baseline plateau. And the higher this number, the more PMOS, because you can imagine that in pressure control, or in pressure support, pressure control, the inspiratory pressure is set by us. And then whatever difference here is because the muscle had to do some effort. So in this case, we don't see any, and a PMI of 0 means that there's no PMOS, or it's consistent with over assistance, if that's your goal. But then you do an end-expiratory pause. So that's why doing these pauses opens your eyes to a lot. And this is a 10-second end-expiratory pause. And you can see that during the 10 seconds that lasted, there was absolutely no PMOS, no effort. It was only this cardiac oscillation. So These are not triggering the ventilator. It's just that the patient is doing no effort. It's absolutely passive. Rob?
Question, you mentioned the PMI. Is that defined for both volume control and pressure control?
No, it's just for pressure support and pressure control. That's the data that it's out there. And again, these are I'm mentioning it more than anything because these are starting to permeate into the literature. And I think that they carry value in the setting of saying, why is the plateau higher than the set inspiratory pressure? And that is usually the presence of PMOS, either inspiratory during this period or expiratory, meaning the patient is exhaling during that period of time. All right. So these are not false triggers. These are this actually is just a patient that is over assisted. And so what you see here is this just a patient that is passive because we are over assisting the patient. The patient was awake looking at us and doing no effort. So this patient was actually over assisted. There was no trigger activity. There was only over assistance. And so I would ask you there, immediately then my goal was to go, I saw the compliance, I saw the pattern here, and I said, well, this is completely a passive patient, and that may be okay. I mean, this patient was on 28% of oxygen and 5 of PEEP. So that raised questions of saying, why is this patient on this? So I walked by, talked to our team, and the team said, oh, our goal is liberation. This patient should move towards trach color. So if your goal is liberation, then the amount of support that we're giving with this algorithm was too much, and we dropped it to 50%. So it dropped from 6.6 liters per minute of tidal volume of minute ventilation, sorry, to 3.3 because it's 50%. That was 100%. And so when we did that, you can now see that the patient is triggering every single breath. You see that? So the little triangles is this patient now breathing on its own and asking for the breaths. I think that an important thing for us to highlight here is that when we drop the 50%, the algorithm was already at the bottom of the curve. If you see this box, it was already at the bottom border of the safety limit for hypoventilation. So we went down by 50%, and the machine did not decrease the tidal volume target. If you see, it's still at 292, and the patient is getting around that. What it did is drop the respiratory rate to be able to deliver less minute ventilation. And as we did that, then the patient started activating the PMOS. Granted, it could be that this 300 is still too much for this patient because of XYZ, and it could be that it's over assisting them. But in this case, it was enough to at least have the PMOS get into shape and be present. Rob?
That's a good analysis.
So to finish up, this is a good review of what ASB is, and we talked about PC-IMV type 3 OI. We talked about how the goal guides the settings to increase the PMOS on these patients, how that change led us to going from all mandatory to all spontaneous breaths. And we talked about this screen, which will help you know what the ventilators is choosing for tidal volume and respiratory rate and how it will behave between the intelligent and optimal targeting. Oh, good question, Arsal. So Arsal is asking, what is better, dropping the tidal volume or dropping the respiratory rate to generate under assistance? So in a patient that is over assisted, do I drop the tidal volume or I drop the respiratory rate? And I think that the answer in general, perhaps, Arcel, it depends on the tidal volume and where are you on the amount that you're giving to the patient. For some of our patients in which we're favoring under assistance, we usually go down to around 4 cc per kilo. Sometimes they have an intrinsic respiratory rate that is above that, and so the only thing that you can drop is the tidal volume. Target, and this is for modes in which we're targeting the tidal volume, or I mean, even if you're using pressure support, you're targeting in a way the tidal volume. So that may be the answer for you. Is in this patient, the first thing is to drop the respiratory rate, and then see what the patient does. And if it's still over assisted, then you would start considering, how do I drop the tidal volume? And in that case, this may not be the right mode, because you're not going to be able to drop below that set number. So the key items for you to recognize, and I want you to, I mean, this is key, and for the fellows and for those that are that have respiratory therapists in the unit, you need to grab your respiratory therapist and walk with them into the room and do both, or ask for those, right? But this needs to be, it gives you the ability to unveil the true source of flow wave deformations. And be aware that if you're trying to liberate patients, over assistance can happen at 100% of support during ASB, or even lower than that. It may be too much for a certain group of patients depending on their state. So the take-home message is, consider the goal of ventilation, and to check your assumptions, a couple of maneuvers will get you there. Rob, give us some words of wisdom.
Well, never forget that when you assume it makes an ass out of you and me.
That's right. That's right. And I do want to highlight, please, we now have the SEVA course program is open to everybody. So if you're interested in attending, if you Google SEVA program CME, the registration page will come out, and that's open to everybody. We want to obviously share the program that we use and grow our knowledge. Thank you very much, and have a great day.